Good afternoon, everyone. Should 3D navigation be the standard of care for MISSABSCON? I am Dr. Shivakumar from Stavya Hospital, Ahmedabad. In 3D OM navigated MISSABSCON, we try to evaluate pedicle screw perforation rate, proximal junction facet joint violation rate, occupancy of pedicle screws rate, and the tip apex distance, and actual modulation of pedicle screws. It was a retrospective study design, and radiological parameters were assessed only. So study period was from January 2019 to August 2022, and patients aged between 18 to 80 were included. Single level MISSABSCON were included, and patients on the either side of the spectrum less than 18 and more than 80 were excluded, and multi-level MISSABSCON cases, deformity, infection, trauma, and tumors were excluded. All the cases were done in OARM asset stealth navigation system, and after prone position and part preparation, tracker reference frame was fixed to the bony point of the circular skin with sutures and nearest to the operative site, and then first CT scan was taken. And under navigation assistance, all the 4 pedicle screw guide wires were inserted. Decompression was planned from the side which was most symptomatic, and decompression was performed, and interbody cage was inserted from the most symptomatic side, followed by insertion of screws under navigation connected with rods. Post-instrumentation, a second CT scan spin was taken to determine the accuracy of hardware, and 230 MIS TLIF patients cases were done during the study period under 3D navigation. 208 patients with full records were available. 832 screws in 208 patients were analyzed. So this is the demographic data. Out of 208 patients, 111 were male and 97 were female. Mean age of the patients was around 48. The most operated level was L4-5 followed by L5-S1 followed by L3-4, and most of the cases were of listhesis followed by disc prolapse followed by lumbar canal stenosis. So this is a literature review of pedicle screw breaches with accuracy ranging from 69% in freehand technique to 96% in CT navigation. We had a similar results with our CT navigation technique of 94.84%, and all the screw breaches were grade 1 and patients were not symptomatic, so nothing had to be done. So this is a summary slide wherein the literature supports, literature quotes accuracy range for freehand of 69 to 71%. With fluoroscopy it is 50 to 78%, and the best is CT navigation 89 to 96%, and we had a similar experience. We report a range of 94.84%. Coming to proximal facet joint violation, we use Park et al. Classification, where type 1 violations, the pedicle screw is itself in the facet joint. In type 2, the pedicle screw head is abutting the facet joint, and in type 3, everything is out, but it's within the 1 mm of the facet joint. So coming to the literature review, the literature quotes proximal facet joint violation rate somewhere between 28% to 65%. And in our study, with the CT navigation, we were able to plan the screws much better, and we report a proximal facet joint violation rate of 2.28%, and all were grade 2 breaches, suggesting only the screw head was abutting the facet joint. And coming to occupancy rate of pedicle screws, it is more relevant to determine whether the upper instrumented vertebral fractures are going to cause. So to calculate occupancy rate of pedicle screws, first you have to measure the length of the screws in the vertebral body in the lateral radiographs, that is A and B for each screws, and then D is the length of vertebral body in the lateral radiographs, and then add A plus B and divide it by 2 into D, then you get the occupancy rate of the pedicle screws. And coming to tip apex distance, it is also relevant in case of the proximal screw cutouts and upper instrumented vertebra fractures. To measure that, we have to measure it in both AP and lateral radiographs. In AP, we have to measure distance between the tip of the pedicle screws to the spinous process. So you get the values A and B for each screws. Then in the lateral radiographs, you have to measure distance of tip of the pedicle screws to the anterior cortex of the vertebral body, and add up all the 4 values, and you get the tip apex distance. Coming to literature, Bowman-Gartner gave the critical value for tip apex distance mainly for the DHS in the proximal femur fractures less than 25 mm, and extending the same concept to the spine. And Oye et al. In 2 papers in the Global Spine Journal, he gave a critical value of occupancy rate of pedicle screw ranging from 73% to 81.8%. With CT navigation, we were able to guide and screw size better with the CT navigation, and we report a occupancy rate of around 78.74%, and tip apex distance well within the limit of less than 25, that is 20.75 mm. We even got occupancy rate maximum to 93% as well. Coming to pedicle screw medialization, we assessed all the 4 screws, that is right upper screw, left upper screw, right lower screws and left lower screw. As you can see, the actual pedicle screw trajectories are around the 16 to 17 degrees in upper screws and 22 degrees in lower screws, and we got a screw angle of approximately 30 to 31 degrees. So we assessed 144 screws in each categories, and pedicle screws were actually more medialized than the pedicle angle trajectories with navigation assist. We got 15 degrees of more medialization in upper screws and 10 degrees of more medialization in lower screws. Coming to limitations of study, this is a purely radiological study, so clinical outcome was not the focus of the study. This was retrospective, non-randomized, and no comparative arms. Coming to conclusion, this is, 3D navigation is useful tool in guiding placement of pedicle screws with high accuracy with respect to pedicle screw perforation, sparing of the proximal facet joint, better medialization, and better sizing of the screws. So this tool is particularly indispensable in MIS cases when the tactile feedback is minimal. Thank you for your time.